We recently had a very nice conference in Dublin on Sickle's novelty on Sickle and thalassemia, and during the conferences novel approaches have been treated. Let's focus on thalassemia first. For thalassemia, data have been presented either for Luspatercept, which is already approved and available in the market in several countries, and Dr. Origa presented data on real life in a large cohort of Italian patients, showing quite a significant improvement in terms of reduction of transfusion burden. So the results are confirming those of the trial, but translated in real life are even more convincing. Of course, there are some let's say, consideration to take into account related to side effect, which includes increase of bone marrow expansion or risk of thrombosis. But both are manageable, so what is important is just to know that they have to be looked at before starting treatment. Another novel, well, not novel because the trial are already completed, approach for thalassemia is Mitapivat, which is a PK activator. Still, I'm not going into the results, but Dr. Kevin Kuo presented the results either in TDT, transfusion-dependent thalassemia, and non-transfusion-dependent thalassemia, and in both cohorts of patients, the results are really very impressive, and we are just waiting to have the drug available for real life. Of course, in thalassemia there are several other non-pharmacological approaches, but molecular, which means gene therapy and genome editing, and also these approaches have been discussed during the conference. Just to move to the sickle cell disease, sickle cell is a more complex scenario in terms of novel approaches. Also for sickle, we may have some molecular approaches, either with gene therapy or genome editing. Particularly with genome editing, the results are very promising. As for the pharmacological approach, the track is more difficult because a couple of drugs have been already were in trials, such as voxelotor and crizanlizumab. Both underwent some re-evaluation. Voxelotor was stopped due to severe complication in some patients, some death also. But now the clinical trial are under re-evaluation to try to better understand what was wrong. And for crizanlizumab, there was a kind of, let's say, resistance to approve it by EMA just because they claimed that there was no superiority compared to hydroxyurea. Glutamine is used in the United States, is not available in Europe, and other molecules are under evaluation. But as I said, for sickle, the way is still long due to the fact that there are different targets in the pathophysiology of sickle cell disease. So we have to find out the right way to go. Mitapivat also has been proved in Sickle, and we are waiting to see some results.